Hi, my name is Dr. Hussein Hadi from the Department of Pathology and Forensic Medicine at Mustansiriya University. In this series of 4 lectures, I will try to cover the endocrine system from the pathological point of view. In the last presentation, I already finished talking about the disorders that could affect the pituitary gland. In addition, some of the thyroid dysfunction was also covered, including hyperthyroidism and hypothyroidism. In this lecture, I will try to cover the rest of thyroidal dysfunction, mainly the autoimmune thyroid disease, the diffuse and multinodular goiter, and hopefully I'll start to talk about the thyroid neoplasm. So, the first topic is an autoimmune thyroid disease. These disorders include thyroiditis and antibody-mediated disturbances in thyroid function that are not necessarily associated with inflammation, exemplified by Graves' disease. Now I will try to outline thyroiditis in more details. The thyroiditis includes a diverse group of disorders characterized by some form of thyroid inflammation. Clinically, significant subtypes are as shown in this figure. First, the Hashimoto thyroiditis. Secondly is the granulomatous decurvan thyroiditis. And finally, the subacute lymphocytic thyroiditis. The first subtype is called chronic lymphocytic thyroiditis or Hashimoto thyroiditis. It is the most common cause of hypothyroidism in areas of the world where iodine levels are sufficient. It is characterized by gradual thyroid failure secondary to autoimmune destruction of the thyroid gland. The age is mostly between 45 to 65 years and is more common in women. For the pathogenesis, Hashimoto thyroiditis is regarded as an autoimmune disease caused by an immune response to thyroid autoantigens. Circulating autoantibodies against thyroid antigens are present in the vast majority of patients. Multiple immunologic mechanisms that may contribute to thyroid cell damage have been identified, including the following. First is the CD8 cytotoxic T-cell mediated killing, and secondly is the cytokine mediated cell death, and the other mechanism is an antibody-dependent cell-mediated cytotoxicity. This figure shows the pathogenesis of Hashimoto thyroiditis, as well as the multiple immunologic mechanisms that may contribute to thyroid cell death, and these include the CD8 cytotoxic T-cell mediated killing of the thyroid epithelial cells. In addition, the cytokine mediated cell death, at which the T-cell activation can lead to the production of inflammatory cytokines, mainly interferon gamma, in the thyroid gland, and this can lead to the recruitment and activation of macrophages and damage to follicles. The other mechanism is an antibody-dependent cell-mediated cytotoxicity, which results from binding of antithyroid antibodies, such as the antithyroglobulin and antithyroid peroxidase antibodies. It is worth to know that the Hashimoto thyroiditis appears to have a significant genetic component. By the morphological appearance of Hashimoto thyroiditis, the thyroid gland usually is diffusely and symmetrically enlarged. Microscopic examination reveals widespread infiltration of the parenchyma by a mononuclear inflammatory infiltrate containing small lymphocyte plasma cells and well-developed germinal centers. The germinal centers seen in this figure mainly on the right side of this image. In addition, The thyroid follicles are atrophic and are lined in many areas by epithelial cells, distinguished by the presence of abundant eosinophilic granular cytoplasm termed Hertel or oxyphil cells, and this is mainly seen on the left side of this image. The interstitial connective tissue is increased and may be abundant. For the clinical features of Hashimoto thyroiditis, we should know that the patient could presented with the painless enlargement of the thyroid, usually associated with some degree of hypothyroidism, often in a middle-aged woman. In addition, the enlargement of the thyroid gland usually is symmetric and diffuse, but in some cases it may be sufficiently localized to raise suspicion for neoplasm. The patients often have other autoimmune diseases and are at increased risk for the development of B-cell non-Hodgkin's lymphoma, which typically arise within the thyroid gland. The relationship between Hashimoto disease and thyroid epithelial cancers remains controversial, with some studies suggesting a predisposition to papillary carcinomas. The second clinical subtype is called subacute granulomatous thyroiditis or decurvent thyroiditis. It is much less common than Hashimoto thyroiditis. It is more common between 30 to 50 years of age, and like other forms of thyroiditis, occurs more frequently in women than in men. In addition, the subacute thyroiditis is believed to be caused by viral infection or an inflammatory processes triggered by viral infections and not by an autoimmune process. The majority of patients have a history of an upper respiratory infection shortly before the onset of thyroiditis. Morphologically, the thyroid gland is firm, with an intact capsule and may be unilaterally or bilaterally enlarged. Histologic examination reveals disruption of thyroid follicles, extravasation of colloid, and infiltrating neutrophils, which are replaced over time by lymphocytes, plasma cells, and macrophages. The extravasated colloid provokes an exuberant granulomatous reaction with joint cells. Healing occurs by resolution of inflammation and fibrosis. Clinical features. The onset of this form of thyroiditis often is acute. It is characterized by neck pain, particularly with swelling, fever, malaise, and variable enlargement of the thyroid. Transient hyperthyroidism may occur as a result of disruption of thyroid follicles and release of excessive thyroid hormone. The leukocyte count and ESR are increased with the progression of the gland destruction. A transient hypothyroid phase may occur. The condition typically is self-limited, with most patients returning to an euthyroid state within 6 to 8 weeks. The other clinical subtype is termed subacute lymphocytic thyroiditis, also is known as silent or painless thyroiditis. The onset follows pregnancy, postpartum thyroiditis. This disease is most likely autoimmune in etiology, as circulating anti-thyroid antibodies are found in a majority of patients. In addition, the histologic features consist of lymphocytic infiltration and hyperplastic germinal centers within the thyroid parenchyma. It mostly affects middle-aged women who present with a painless neck mass or features of thyroid hormone excess. The initial phase of thyrotoxicosis, which is likely to be secondary to thyroid tissue damage, is followed by return to a neothyroid state within a few months, except for possible mild symmetric enlargement. The thyroid appears normal on gross inspection. I already finished the talking about the thyroiditis. Now I will move to talk about the second entity of autoimmune thyroid disease, which is called the Graves' disease. Graves' disease is the most common cause of endogenous hyperthyroidism. It is characterized by a triad of manifestations. First is the thyrotoxicosis caused by a diffusely enlarged hyperfunctional thyroid. Secondly is an infiltrative ophthalmopathy with the resultant exophthalmos in 40% of patients. Thirdly is the infiltrative dermopathy, pretibial myxedema. It is a localized lesions seen in a minority of cases, mainly on the shin, and usually appear as papule nodules and plugs. It is important to know that the glucosaminoglycan deposition and lymphoid infiltrates are responsible for the ophthalmopathy and dermopathy. Regarding the incidence of Graves' disease, it has a peak between 20 to 40 years, with women being affected up to 7 times more commonly than men. In addition, genetic factors are important. The incidence is increased in relatives of affected patients, and the concordance rate in monozygotic twins is as high as 60%. As with other autoimmune disorders, a genetic susceptibility to Graves' disease is associated with the presence of certain human leukocyte antigen haplotypes, specifically HLA-DR3. In regard of pathogenesis of Graves' disease, many manifestations are caused by autoantibodies against the TSH receptor that bind to and stimulate thyroid follicular cells, independent of endogenous trophic hormones. Multiple autoantibodies are produced in Graves' disease, including the following. First is the thyroid stimulating immunoglobulin. This immunoglobulin G antibody binds to the TSH receptor and mimics the action of TSH, stimulating adenyl cyclase, with the resultant increased release of thyroid hormones. It is relatively specific for Graves' disease. Secondly is called the thyroid growth stimulating immunoglobulins, also directed against the TSH receptor. These antibodies have been implicated in the proliferation of thyroid follicular epithelium. The third one is called the TSH binding inhibitor immunoglobulins. These anti-TSH receptor antibodies prevent TSH from binding to its receptor on thyroid epithelial cells and may inhibit thyroid cell function. The coexistence of stimulating and inhibiting immunoglobulins in the serum of the same patient is not unusual, and may explain why some patients develop episodes of hypothyroidism. In addition, it is important to know that T-cell mediated autoimmune phenomenon also is involved in the development of the infiltrative ophthalmopathy characteristic of Graves' disease. In Hashimoto thyroiditis and Graves' disease, the frequency of other autoimmune diseases such as SLE, pernicious anemia, type 1 diabetes, and Addison disease is increased. Morphologically, in Graves' disease, the thyroid gland is enlarged, usually symmetrically enlarged. due to diffuse hypertrophy and hyperplasia of the thyroid follicular epithelial cells. The gland is usually smooth and soft, and its capsule is intact. Microscopically, the follicular epithelial cells are tall, columnar, and more crowded than usual, as you can notice here in this figure. This crowding results in the formation of small papillae projecting into the follicular lumen, and such papillae lack fibrovascular cores, in contrast with those of papillary carcinoma. The colloid within the follicular lumen is pale with scalloped margins. In addition, lymphoid infiltrates, consisting predominantly of T cells with fewer B cells and mature plasma cells, are present throughout the interstitium. Germinal centers are common. So, to sum up, the Graves' disease, within it, you can notice microscopically the follicles are lined by tall columnar epithelium, and you can notice the scalloped appearance of the colloid. Clinical manifestations of Graves' disease include those common to all forms of thyrotoxicosis, as well as those associated uniquely with the Graves' disease, which include the diffuse hyperplasia of the thyroid, ophthalmopathy, and dermopathy. The degree of thyrotoxicosis varies from case to case. Increased flow of blood through the hyperactive gland often produces an audible bruit. Sympathetic overactivity produces a characteristic wide staring gaze and lid lag. In the left image, for a patient with hyperthyroidism, you can notice a wide-eyed staring gaze caused by overactivity of sympathetic nervous system. This is one of the classic features of this disorder. In the right images, you can notice a patient with a lid lag, which is an abnormal white rim of sclera visible between the upper eyelid and the iris when a person moves the eyes downward. This is a sign of hyperthyroidism. So the lid lag means delay in moving the eyelid as the eye moves downward. The other clinical manifestation of Graves' disease is ophthalmopathy, result in abnormal protrusion of the eyeball. This is called exophthalmos. The exophthalmos may persist or progress despite successful treatment of thyrotoxicosis, sometimes result in corneal injury. With this image, you can see a patient with exophthalmos as both lids moved away from center with sclera visible below or all around the iris. And it's important to differentiate exophthalmos from the lid retraction, at which the upper lid raised while the lower lid remains normal in its position. The Graves' disease is also characterized by infiltrative dermopathy, involves the skin overlying the shins, manifests as scaly thickening and induration of the skin, peritoneal myxedema. The skin lesions are slightly pigmented papules or nodules and often have an orange pale texture. The laboratory findings of patients with the Graves' disease include elevated serum free T4 and T3 and depressed serum TSH because of ongoing stimulation of the thyroid follicles by thyroid stimulating immunoglobulins. Radioactive iodine uptake is increased diffusely. The next subject is the diffuse and multinodular goiter. The goiter is defined as enlargement of the thyroid. It is the most common manifestation of thyroid disease. Diffuse and multinodular goiters, most often caused by dietary iodine deficiency with impairment of thyroid hormone synthesis, leads to a compensatory rise in the serum TSH, which drives the hypertrophy and hyperplasia of the thyroid follicular cells, and ultimately enlargement of the thyroid gland. The degree of thyroid enlargement is proportional to the level and duration of thyroid hormone deficiency. These compensatory changes overcome the hormone deficiency and maintain a euthyroid metabolic state. However, if the underlying disorder is severe, for example a congenital biosynthetic defect, the compensation may be inadequate, resulting in goitrous hypothyroidism. The pathogenesis: goiters can be endemic or sporadic. First, we'll talk about the endemic goiter. The endemic goiter occurs in geographic areas where the diet contains little iodine. It is used when goiters are present in more than 10% of the population in a given region, commonly in mountainous areas. With increased availability of dietary iodine supplementation, frequency and severity of endemic goiter have declined significantly. The other is sporadic goiter, which occurs less frequently than endemic goiter. The condition is more common in females than in males, with a peak incidence in puberty or young adulthood, when there is an increased physiologic demands for T4. We should know that the sporadic goiter may be caused by excessive ingestion of substances that interfere with thyroid hormone synthesis, such as calcium and vegetables belonging to the cruciferae family, for example cabbage and cauliflower. In other instances, goiter may result from inherited enzymatic defects that interfere with thyroid hormone synthesis, called the dysharmonogenic goiter. In most cases, however, the cause of sporadic goiter is not apparent. For the morphology, TSH-induced hypertrophy and hyperplasia of thyroid follicular cells usually result in diffuse symmetric enlargement of the gland, diffuse goiter. The follicles are lined by crowded columnar cells, which may pile up and form projections similar to those seen in Graves' disease. If dietary iodine subsequently increases, or if the demands for thyroid hormone decrease, the follicular epithelium involutes to form an enlarged colloid-rich gland. This is called the colloid goiter. The cut surface of the thyroid in such cases usually is brown, glassy appearing, and translucent. With time, recurrent episodes of hyperplasia and involution combine to produce a more regular enlargement of the thyroid, termed multinodular goiter. Almost all long-standing diffuse goiters convert into multinodular goiters. They are multilobulated, asymmetrically enlarged glands. On cut surface, irregular nodules containing variable amounts of brown gelatinous colloid are evident. Older lesions often show areas of fibrosis, hemorrhage, and cystic change. The microscopic appearance includes colloid-rich follicles lined by flattened, inactive epithelium and areas of follicular epithelial hypertrophy and hyperplasia. This is a figure for multinodular goiter. Grossly, in the left panel, there is a coarse nodular gland containing areas of fibrosis and cystic changes. Microscopically, in the right panel, you can notice a compressed residual thyroid parenchyma on the periphery, mainly on the left side of the image. In addition, the hyperplastic follicles containing abundant pink colloid within their lumen can occur, and you can see it mainly on the right side of the image. Clinical features. The dominant clinical features is goiter. It may cause airway obstruction, dysphagia, and compression of large vessels in the neck and upper thorax, so-called superior vena cava syndrome. Multinodular goiters typically are hormonally silent, but a minority, about 10% over 10 years, manifest with thyrotoxicosis secondary to the development of autonomous nodules that produce thyroid hormone independent of TSH stimulation. This condition, known as toxic multinodular goiter or Plummer syndrome, is not accompanied by the infiltrative ophthalmopathy and dermopathy of Graves' disease associated thyrotoxicosis. The incidence of malignancy in long-standing multinodular goiter is low, less than 5%. Goiters that demonstrate sudden changes in size or associate symptoms, for example, hoarseness. The next subject tried to be covered here is thyroid neoplasm. Majority of solitary nodules of the thyroid prove to be either benign adenomas or localized, non-neoplastic conditions. For example, a dominant nodule in multinodular goiter, simple cyst or foci of thyroiditis. You should know that the carcinomas of the thyroid are uncommon, accounting for less than 1% of solitary thyroid nodules. Several clinical criteria provide a clue to the nature of a given thyroid nodules. These include: first, solitary nodules in general are more likely to be neoplastic than are multiple nodules. Secondly, is that the nodules in very young, less than 20 years of age, or very old, greater than 70 years, individuals are more likely to be neoplastic. In addition, nodules in males are more likely to be neoplastic than are those in females. A history of radiation exposure is associated with an increased incidence of thyroid malignancy. Finally, you should know that the nodules that take up radioactive iodine in image studies, called the hot nodules, are more likely to be benign, so that the cold nodules is most likely to be malignant. Morphologic evaluation of thyroid nodule by fine needle aspiration combined with the histologic study of surgically resected thyroid tissue provide the definitive information about the nature of the nodule. The rest of this presentation, I will try to outline the benign thyroid neoplasm, which is the thyroid adenomas, as well as the thyroid carcinoma, which is the malignant neoplasm of the thyroid, including the papillary carcinoma and follicular carcinoma. Whereas the other type, which is the anaplastic carcinoma and the medullary carcinoma, will hopefully be covered in the next lecture. So first, the thyroid adenomas. They are benign neoplasm derived from follicular epithelium. The follicular adenomas usually are solitary. On clinical and morphological grounds, they may be difficult to distinguish from a dominant nodule in multinodular goiter or from less common follicular carcinomas. Although the vast majority of adenomas are non-functional, a small proportion produce thyroid hormones, causing clinically apparent thyrotoxicosis. In general, follicular adenomas are not forerunners to carcinomas. However, shared genetic alterations support the possibility that at least a subset of follicular carcinomas arise in pre-existing adenomas. Driver mutations in the TSH receptor signaling pathway play an important role in the pathogenesis of toxic adenomas. Activating gain of function somatic mutations in one of two components of this signaling system, most often the gene encoding the TSH receptor itself, and less commonly the alpha subunit of the guanine, allow follicular cells to secrete thyroid hormone independent of TSH stimulation, and this is the thyroid autonomy. Overall, somatic mutations in the TSH receptor signaling pathway are present in slightly over half of toxic adenomas. A minority of non-functioning follicular adenomas, less than 20%, exhibit mutations in RAS or other genes, genetic alterations that are shared with the follicular carcinomas. For the morphology, the typical thyroid adenoma is a solitary, spherical lesion that compresses the adjacent non-neoplastic thyroid. The neoplastic cells are demarcated from the adjacent parenchyma by a well-defined intact capsule. This figure shows the follicular adenoma of thyroid gland, and you can notice a solitary well-circumscribed nodule in this gross specimens. Microscopically, the constituent cells are arranged in uniform follicles that contain colloid. Occasionally, the neoplastic cells acquire brightly eosinophilic granular cytoplasm called oxyphil or Hertel cell change. As you can see in this microscopic view at high power, the Hertel cell adenoma. The Hertel cell arising from the follicular epithelium of the thyroid gland. It is larger than a follicular cell and its cellular material stained pink. It is important to know that the careful evaluation of the integrity of the capsule critical in distinguishing follicular adenomas from follicular carcinomas, which demonstrate capsular and/or vascular invasion. Clinical features. They manifest as painless nodules, often discovered during a routine physical examination. Larger masses may produce local symptoms such as difficulty in swallowing. In addition, individuals with toxic adenomas may present with features of thyrotoxicosis. After injection of radioactive iodine, most adenomas take up iodine less avidly than normal thyroid parenchyma, and this is the called nodules. Toxic adenomas, however, appear as warm or hot nodules in the scan. Because of the need for evaluating capsular integrity, the definitive diagnosis of thyroid adenoma can be made only after careful microscopic examination of the resected specimen. The thyroid adenomas carry an excellent prognosis and do not recur or metastasize. The next is malignant tumor, thyroid carcinomas. A female predominance among patients who develop thyroid carcinoma in the early and middle adult years. By contrast, in childhood and late adult life are distributed equally between males and females. Most thyroid carcinomas, except medullary carcinomas, are derived from the thyroid follicular epithelium, and the majority are well differentiated lesions. In addition, the medullary carcinomas arise from the parafollicular C cells rather than follicular epithelium. The major subtypes of thyroid carcinoma and their relative frequencies are as follows. First is papillary carcinoma, which is the most common type and accounts for greater than 85%, followed by the follicular carcinoma, which accounts for 5 to 15% of cases. In this lecture, I will talk about these two carcinomas. In addition, there is other subtypes, which is the anaplastic undifferentiated carcinoma and medullary carcinoma, which accounts for about 5% of cases. For the pathogenesis, we should know that multiple genetic pathways are involved in thyroid carcinogenesis. The genetic alterations in the three follicular cell-derived malignancies are clustered along two oncogenic pathways that lie downstream of growth factor receptors and RAS, the MAP kinase pathway and the phosphatidylinositol 3 kinase pathway. Regarding environmental factors, the major risk factor predisposing to thyroid cancer is exposure to ionizing radiation, particularly during the first 2 decades of life. It has been noticed that there was an increase in papillary carcinomas among children exposed to ionizing radiation after the Chernobyl nuclear disaster in 1986. In addition, deficiency of dietary iodine and by extension an association with goiter is linked with a higher frequency of follicular carcinomas. The first subtype of thyroid carcinoma is called papillary carcinomas, and as I said, they are the most common form of thyroid cancer. These tumors may occur at any age and associated with the previous exposure to ionizing radiation. For the morphology of thyroid carcinoma, they are solitary or multifocal lesions. Some tumors may be well circumscribed and encapsulated. Others infiltrate the adjacent parenchyma and have ill-defined margins. The cut surface sometimes reveals papillary foci that point to the diagnosis. The microscopic hallmarks of papillary neoplasm include the following: branching papillae having a fibrovascular stalk covered by a single to multiple layers of cuboidal epithelial cells. They are well defined, uniform but more pleomorphic or even anaplastic morphologies may be seen. The next important microscopic hallmarks of papillary neoplasm is nuclear features. The nuclei with finely dispersed chromatin, which imparts an optical clear or empty appearance, giving rise to what is called the ground glass or orphan eye nuclei. In addition, invaginations of the cytoplasm often give the appearance of intranuclear inclusions, called pseudo-inclusions or intranuclear grooves. These nuclear features are sufficient for the diagnosis of papillary carcinoma, even in the absence of papillary architecture. In addition, concentrically calcified structures termed psammoma bodies are often present within the lesion, usually within the cores of papillae. These structures are almost never found in follicular and medullary carcinomas. The final microscopic hallmarks of papillary neoplasm that we need to know is, that the foci of lymphatic invasion by tumor are often present, but involvement of a blood vessel is relatively uncommon. This figure is for the papillary carcinoma of the thyroid gland. Grossly, you can see the visible papillary structures in figure A. In addition, you can notice that the well-formed papillae in figure B and the papillae are lined by cells with characteristic anti-appearing nuclei. This is called the orphan annuli nuclei, which is noticed in figure C. In figure D, the cells obtained by fine needle aspiration of papillary carcinoma with the characteristic intranuclear inclusions are visible in some of the aspirated cells, as indicated by the red arrows. Clinically, papillary carcinomas are non-functional tumors, so they manifest most often as a painless mass in the neck, either within thyroid or as metastasis in a cervical lymph node. It is worth to know that the papillary carcinomas are indolent lesions with the 10-year survival rate in excess of 95%. In a minority of patients, hematogenous metastases are present at the time of diagnosis, most commonly to the lung. The next major subtypes of thyroid carcinoma is termed follicular carcinoma. The follicular carcinomas account for 5 to 15% of primary thyroid cancers. They are more common in women, occurring in a ratio of 3 to 1, and manifest at an older age than papillary carcinomas, with a peak incidence between 40 to 60 years of age. In addition, it is more frequent in areas with dietary iodine deficiency. On microscopic examination, most follicular carcinomas are composed of uniform cells forming small follicles, reminiscent of a normal thyroid. In other cases, follicular differentiation may be less apparent, as with follicular adenomas, Hürthle cells variant of follicular carcinomas may be seen. The follicular carcinomas may be widely invasive, infiltrating the thyroid parenchyma and extrathyroidal soft tissues, or even minimally invasive. This figure is for follicular carcinoma of the thyroid gland. As you can see, a few of the glandular lumina contain recognizable colloid. It is important to know that the distinction between follicular adenoma and carcinoma requires extensive histologic sampling of tumor capsule thyroid interface to exclude capsular and/or vascular invasion. This figure is to demonstrate the capsular invasion, which is critical in distinguishing follicular adenomas from follicular carcinomas. As you can notice in the left-sided microscopic image, which is for the adenomas, you can notice a fibrous capsule, usually thin, but occasionally more prominent, surrounding the neoplastic follicles, and no capsular invasion is seen. This is indicated by the black arrow. In addition, compressed normal thyroid parenchyma is usually present external to the capsule, which is mainly seen at the top of the image. In contrast, in figure B in the right side microscopic image, which is for the follicular carcinoma, you can demonstrate the capsular invasion that may be minimal, as in this case. Clinically, follicular carcinomas manifest most frequently as solitary cold thyroid nodules. In rare cases, they may be hyperfunctional. In addition, these neoplasms tend to metastasize through bloodstream, showing hematogenous dissemination to the lung, bone, and liver. In contrast with papillary carcinomas, regional nodal metastases are uncommon. These are some suggested readings for the thyroid nodules and thyroid carcinoma. Hopefully, you will find it useful for you. Thank you.